Sorry, I was a little bit late, and thank you to the organizers, Professor Khan, that you invited me here to talk about brain trauma, but also by spine. I had some talks, and also I thank Professor Sharif for yesterday during the meeting. Thank you very much. So I'm a little bit provocative with this kind of approach for some of you. It's already for some years that we change from randomized controlled trials to medical practice-based evidence. I will explain that in a moment. But that is quite provoking, especially for scientists, and not so much for us as neurosurgeons. So these are my conflicts of interest. I'm a spine surgeon and a trauma surgeon, and I receive quite a lot of money, not personally, but my department, to run studies on spine and brain trauma. So this is a slide where neurotraumatology is all about, and I'm not alluding to the text, but to the picture. We as neurosurgeons should be more aware of the total chain of care and not only at our surgical part. So be it brain, spine, or nerve injury, we should not only do the surgery, but also be aware of what happens before surgery and after. So the total chain of care is important, and we sometimes lose that part. And I know that here in Pakistan, there's a lot of development in prevention of trauma care. In my country, we are, as neurosurgeons, not involved, but getting more and more involved, for instance, in the use of helmets. So this is a slide you all know. A lot of disability years lost in brain trauma. And when you compare that to Alzheimer's disease or cerebrovascular disease, where most of the money is going to for good studies, then you see that neurotrauma is on top. And politicians are now becoming aware, but for a long time were not. But we as neurosurgeons should also be aware that it is an important part of the world burden of trauma. Mortality has going down in the past century, but nowadays it's a little bit going up. And if you look at our evidence-based guidelines, nothing has changed between 1535 and now. So in 1535 in Italy, this Bergense said, professor of anatomy, if you have an hematoma and the distance, and you open up the skull, and the distance between the skull and the brain is 1 fingertip, it's 1 centimeter, then you can proceed with surgery. Nowadays, BTF guidelines say an acute subdural hematoma has a minimal diameter of 1 centimeter. So there's no difference between 1535 and our current times. And hopefully, in the future, we will have more evidence. So this is the morphology we look at: brain injury, CT scan, Glasgow Coma scale, systematic responses, reading, and that's all we have. And I'm very proud that I'm part of this group. We all know that there's the United States track TBI, and in Europe and the parts of Asia and Australia, we have center TBI. I just called by Andrew Peul. I was very proud, but I'm Wilco Peul, and Andrew is not here. He's now running a very big meeting in Europe. And David Menon, they developed this new kind of studies. And our treasurer in this area is this guy. Most of you don't know him, but he's a real scientist. And he's always a little bit laughing when we have discussions as neurosurgeons and neurocritical care physicians about this evidence. So this is changing. I showed it earlier this week. Young patients become older, so we see a rise in the elderly age. In center TBI, the median age is 50 in the core data, 55 in the registry data. And in center TBI, we do not randomize. But we have our dilemma. The patient has brain trauma, comes in, what to do? Do we perform surgery or don't we perform surgery? Do we do an ICP monitoring or do we not? And also in the rehabilitation phase, there are a lot of differences. So just to show you, an older man, he's a little bit older than I am, 72 years, had a brain trauma, acute subdural hematoma. We just looked in our area, Netherlands and the Dutch-speaking part of Belgium, how would you treat this patient? And we were astonished. So in my small area of the world, very small country, very homogeneous trained surgeons, there's a huge practice variation. So if you see case 4, the area is the dark area is my area, dus Leiden, The Hague, and Rotterdam. And the other area is the eastern part. So they don't operate for the same case. We ask them, are you willing to randomize? Yes, we are willing to randomize. But will your clinic be part of the study? No, they didn't want that. So that's a discussion. So we cannot randomize them. So it's difficult. TBI, heterogeneous disease, different treatments, and there's big variation between surgeons. And there's very low evidence treatment. And same is true for spinal cord injury. And then after our treatment, when we look in detail what happens at the subacute phase in rehabilitation, how is the practice variation there between countries or even within countries? It's huge. It's enormous. And we have to be aware that we know what a patient can, what he does and stays doing, and also on long-term follow-up. So this is all the people busy with brain trauma. It's a Gordian knot, and we as neurosurgeons should be more in control, again, becoming more in control of this whole area, not as the principal leader, but as a kind of coordinator. So what about evidence? This is what we all wanted, how we were trained. Do a randomized control trial, blue pill, red pill. Just to compare that to Randy's study, the TRIP study, he did that in a certain population. And this is the study population, and then you have the target population, and now the discussion goes on about the TRIP trial results. Can we do that worldwide? And the same is true for Hutch's study for rescue ICP. There was also a population in a certain area, Western Europe. Can we proceed to generalize it and that there is no difference after the study being done between populations? So can we randomize all those things? We could randomize. Randy did a very good job in randomizing. It's quite difficult to do that. It's a top sport to do that. But can we randomize everything? This parachute study showed we cannot randomize everything, because if you would randomize the usefulness of parachute, you would have a very difficult ethical problem. Jumping out of the airplane, putting on your randomized knot. How about severe TBI? Can we randomize this patient? We don't think so, but there is variation. So then you use it the other way around. So you go from the differences between locations. Sorry, this Dutch, those locations. You look at all the variables. You have to measure a lot. So it's a lot of mathematical modeling. And after measurement, you go back to the population, to the target, and then you go back to your research question. And the latter, the research question, is quite frequently forgotten. In Center TBI, big study, a lot of money, we didn't have a good research questions. So we first received the money because it was necessary, and afterwards we developed the research question. Do we have to operate on acute subdural hematoma in that and that score? And then you can measure. So that's Center TBI, and we look at a lot of things. I go a little bit quickly, but if you look at all the variables which we measure, it's looking at genomics, it's looking at biomarkers, it's looking at CT scan, but also an MRI. But the MRI was very difficult to do in acute phase. So only in some hospitals like in Cambridge, where you have the Walt Disney of critical care being an MRI unit besides the ICU, it was possible to do MRIs. So a lot of patients were included, 5,500 patients. We look at morphology, we look at genetics. Again, I do not go into detail. I'm very interested in the critical care part and inflammation of the host response. If we can predict that, then we can act on that and we can modify. It's useless to study something which you cannot modify. And in the past, we studied a lot which we could not modify. And then the biomarkers. It's quite sexy to talk about biomarkers, but we don't really know what happens in severe brain injury. And we have to know that. So a lot of bioinformatics, that's the toolbox of Ewout Steyerberg. He loves to talk about all things, and I love to talk about prevention and precision medicine. And then in the future, best practice will be done. So to conclude, as neurosurgeons, we should be aware that not everything can be randomized, but we should be back in control in brain trauma clinical work, but also in the research. Thank you very much.